Okay, good morning, everybody. It looks like, all right, no one's in the waiting room, so we'll go ahead and get started. My name is Sandra McGrew, and I am the Director of Communications here at the Arkansas Center for Health Improvement. A couple of quick housekeeping items before I turn it over to Nate. You are all muted at the moment, just so that we don't have any background noise. So when during the question and answer period, you may unmute yourself if you would like to ask a question, or you can ask a question in the chat feature, which if you look at the bottom of your screen, there should be a chat box. If you open that up, click it, and then on the right-hand side, you'll have a little message chat feature there, and you can put your questions in during our call today. And that is it. I will go ahead. Nate, I just want to make sure you unmute yourself and take it away.
Can you hear me?
We can.
Good. Thanks, Sandra, for setting this up, and thanks to ACHI and Dr. Thompson. Before we get started here, we're wrestling at the library like everybody else is with how to do things we've never done before. And we've been doing, I think, successful things with delivering services remotely. The curbside pickup has been successful. We've served over 61 or 2,000 meals at our branches with the help of partners at the school district and the Clinton Center. And we've done a lot of good virtual programming. Last night, there was one about sleeping during difficult times with some folks from Hendrix and UA Little Rock. But everybody's asking, when is the library going to open? When's the library going to reopen? I was down at D. Brown yesterday with the meal disbursement, and 2 or 3 people drove up, not for meals, but wanted to know if the library was open. And yesterday afternoon, I got a text from Congressman French Hill, Nate, when's the library reopening? Fortunately, we have a tentative date, June 8th, and we have a plan that we've sent over to Dr. Thompson to look at. I emailed it this morning to the governor's office to ask if they want to send it over to the health department. But I wanted Dr. Thompson to talk to all of us about the virus generally, what people are thinking about it, what the trends are. I sat in on one of his presentations a week or so ago and was very impressed with the breadth of the information, the practical use of the information, and wasn't surprised, but Joe's ability just to convey all that to a lay audience. So I asked him then, and he graciously agreed to do a similar project for us. And we are ready to go with that. He'll go through his slides, and then we'll have some questions that we'll post in you can post in the chat room. But let me tell you a little bit about Joe. I should call him Dr. Thompson, but he and I have known each other longer than either one of us would like to admit. Our kids grew up together, but he's professionally has quite an impressive array of accomplishments. He's a pediatrician by training and background. He's a professor in the colleges of medicine and public health at UAMS. He is the president and CEO of Arkansas Center for Health Improvements. She's been around for over 20 years. And Joe is not just a think tank guy, which is what the ACHI is, a policy driver. He's also very practical. I say that because he's worked for both Republican and Democratic governors. He was the state's first Surgeon General. And he's effectively been responsible for both some of you on this call are probably not old enough to know this, but a number of years ago when we outlawed smoking in most public places, that was Governor Huckabee, some tobacco settlement money, and Joe Thompson, who were responsible for that. And then more recently, Governor Beebe and Dr. Joe Thompson were 2 of the biggest drivers in getting the expansion of Medicaid under what was then called the private option. So Joe's been worn a lot of hats, done a lot of things. I also know from our relationship that he has had lots of opportunities outside of Arkansas, in Washington and other bigger states, but He's a native of Conway and he loves Arkansas and he stayed here. We're grateful. And we're grateful today that he's going to talk to us a little bit about the virus and what we might need to know as librarians as we prepare to reopen on June the 8th. I texted back to Congressman Hill yesterday that we were tentatively reopening on June the 8th. So unless something happens to those numbers, we're going to have to live by that. Joe, take it away.
Well, thank you, Nate. And let me just, before I start off, thank you and all of your team for your presence and your contributions, both before COVID-19 and particularly over these last couple of months. It's hard to believe that we've only been in this 10 or 12 weeks, but that is the case. I'm going to ask Sandra McGrew, who y'all just saw earlier, to drive for us here. Sandra, if you can pull up, we're going to do a slideshow that I've been doing with around the state with the Municipal League, Chamber of Commerce. Nate mentioned our center. We've been around about 20 years. I would encourage folks to come to our ACHI.net. We're really trying to work on having our healthcare system, our systems be better, our communities be more healthy, and supporting individuals with healthier choices. We were cruising along, fighting the e-cigarette battles and trying to keep the insurance world going and trying to have telemedicine become more available in rural Arkansas. And then with the next slide, sometime late last year, probably in some of the markets overseas in China, in Wuhan, there was what has happened before, a virus which has historically been only in animals, jumped to human. Now, it wasn't the virus jumping to the first human that was the problem. It was the virus that jumped to the first human, then starting to jump between humans. So it was the human-to-human transmission that broke out late last year. Most likely, I think there's 99% certainty it was in Wuhan. We had some reports from earlier. This was called a novel coronavirus. Now, the coronavirus itself, there are about 100 different strains of the coronavirus. Most of those don't infect humans at all. They're in bats, they're in pigs, they're in animals. One of the common coronaviruses that is in humans is the common cold. It's a coronavirus. So this new coronavirus, the novel coronavirus, and they named it number 19, jumped to humans and started what we now have as a worldwide pandemic. It's a pandemic because none of us as humans anywhere in the world had ever seen this virus before, so none of our immune systems even recognize it as a threat, and none of us have any immunity to it, so it is spreading rapidly. Here's where we are as of this morning in the United States with over 1.5 million cases, approaching 90,000 reported deaths. Unfortunately, our state, while we didn't have an early exposure, we are now having community-acquired COVID-19 in almost every county across the state. We have about 4,800 known cases, a little over 1,000 that are still active. Today we have 77 people that are hospitalized, 12 on the ventilator. Our deaths hit the century mark yesterday. The active cases or the cumulative cases and the recoveries at 4,800 and 3,600 are probably significantly below what we actually have experienced. We've had a restricted number of tests when this started out. You'll see the darker blue counties there are where we have higher concentrations of cases, but it's now virtually statewide. I do want to point out a couple of hotspots that are in our region. Both Memphis in Shelby County and Shreveport in Caddo Parish. Memphis has almost as many cases and deaths as we had for the whole state of Arkansas, and Shreveport has 50% more deaths than we have in the whole state of Arkansas. So I would strongly advise folks to try to avoid traveling to Memphis or to Shreveport, and to, if you got relatives coming in, have them do some quarantine efforts for the first few days that they're here with you. Now, moving forward, this thing is worldwide. I mentioned that there's some discrepancies on what is being reported. Some nations reporting more diligently than others. We now have the most cases and the third highest per capita rate on the next slide of any nation in the world. I think when we get to the end here, we're going to need to do an after-action review to see what went wrong, because there's no real reason that we should have more cases than any other nation in the world, and the third highest behind Spain and Belgium for the number of confirmed cases in our populations. But it's here and we're having to deal with it. And so let's jump in some to try to understand what's going on. There are four really important questions that I think, we're bombarded by news, but this is what, if you listen to hear, and I'll try to assimilate kind of my vantage point of what's going on. The first is, how fast does this virus actually spread? This is called the R0 or R0. This is the number of people an infected individual is likely to infect. People think this virus is around 2 or 3. So one person can infect 3. Well, if 3 infect 3, that's 9. If 9 infect 3, now you're up to 27. You see how fast this can kind of go. The second important question is, how deadly is this new virus? This ultimately will be called the case fatality rate, the proportion who get the infection who actually die from it. The third is, who's at most risk for these adverse effects? In other words, what are the characteristics of individuals that are most likely to have an adverse outcome when infected? And then the fourth question is, what can we do about it? This is a new virus. We have no antibiotics or no antiviral drugs that are known to work. We have no vaccine. We have no protections against it. So the first phase is kind of our individual actions of good hygiene, washing your hands frequently, cleaning around you, trying to prevent your spread should you become infected. The second are collective actions, which we have gone into and we'll touch on. These are some of the efforts that we've gone in, as a public, limiting larger groups, shutting down bars and restaurants. And then the third area is public health actions. There are kind of 3 areas there. One are public health directives, which you've heard Secretary Nate Smith and the governor putting out. The second are treatments. We have coming online new antiviral drugs or new immunomodulating drugs. We'll touch on those. And then obviously the third, which is a distant way away, is to have a vaccine that we could actually get without having to have the infection itself. Now, how does this virus compare with other infectious diseases? You can see along the bottom or the x-axis, this is how infectious a virus is, that R0, the average number of people infected by each sick person. And you can see measles over here on the far right is one of the most infectious viruses that we know. Chickenpox also very infectious. You see on the vertical axis or the y-axis going up how fatal a condition is. So the higher it is on this graph, the more fatal it is. You see the bird flu, you see the Middle Eastern respiratory syndrome, which was caused by a coronavirus, Ebola, SARS. Those are highly deadly viruses. Of note, the more deadly a virus is, the less infectious it is because it kills its host faster, so it doesn't spread. A person can't infect as many people. For the most characteristics that we know about this virus, it's somewhere in the pink box. The spread is one person will infect somewhere between 2 and 4, and the fatality rate is somewhere around 1%. Now, 1% doesn't sound to be many until you actually consider that since none of us have any immunity, if all of Arkansas or even half of Arkansas got the virus and the death rate was 1%, 1% of 1.5 million people is a lot of deaths. So this is why this new virus that is very infectious, about as infectious as the common cold and more infectious than the seasonal flu, and has a 1% to 2% death rate. This is why we have gone into what we have done over the past 2 months. Now, people hear flattening the curve, and what we have undertaken is really to try to keep all of us from getting infected early and overwhelming our healthcare system. I think somewhat mistakenly is a belief out there that we can keep from getting this virus in perpetuity. We're probably, many of us, going to become infected and hopefully have mild to moderate symptoms. But if we have more serious symptoms, we want the healthcare system to have the capacity to take care of us. So this really was the primary goal of all of the social distancing and public health efforts, has been to keep all of us from getting the virus at one time and overwhelming the capacity of our healthcare system. And that's the flattening of this curve. We're now in this green space where we are having more cases that we contract each day, but we're also being able to treat patients well and try to keep our mortality low. If I go to the next slide, these are some of the steps that we have put in place. You know, it's hard to believe this is May the 18th, 19th. It was just March the 11th that a public health emergency was declared. The 13th, telemedicine were relaxed. The 16th, the visitation was halted at correctional facilities. It was just a day or two, over 2 months ago, that public schools shut down. It seems like it was a year ago to many of us. You know, barbers, beauty shops, cosmetology establishments on the 25th, restriction of gatherings to no more than 10 on the 27th, elective surgeries postponed on the 3rd, businesses going into social distancing on the 4th, testing recommendations finally relaxed. We didn't have enough tests early in April to be able to test everyone who needed to get a test. So these were things that we systematically put in place. The state has gotten criticized, I think, inappropriately, and the governor in particular, for not having a shelter-in-place order. I think we effectively achieved shelter-in-place by some of those kind of collective actions and these public health directives that went into effect. And I think over this course of time, we did not see that purple spike in the curve. We are starting to see cases. When we look over the last 2 months on the next slide at the new positive cases, and here the orange cases are those that are in our correctional facilities. The blue portion of each bar are those that are in, you know, community acquired cases. We did flatten that curve, and we are now, you know, in that green space. You look, this is what the governor reports each day, the 7-day rolling average. We had our highest spike to date about the 3rd week of April. It came down as, you know, we relaxed a little bit. It's starting to come back up. Our center added this community 7-day rolling average because the prisons are kind of a unique situation. It really, for most of us and for you as you reopen, it's the community potential for infection that is most concerning. We do see an uptick over the last several days. Hopefully that'll flatten out. The next slide is where we are in hospitalizations. And again, this was our primary concern, is that we would overwhelm the hospital capacity. You know, and right now we've got about 80 hospitalized individuals. We have been running between 70 and 80 over the last week or so. I think we're good unless we start to see that number get up above 100, 120. We have the capacity to be able to take care of folks. The daily active cases on the next slide are those that are considered actively infected and infectious at this point in time. And again, we got control of it in mid to late April. You saw that curve come down. I think we're all cautiously reopening and getting ready to have more or less restrictive activities. But I think you see that stair step up here in May, and that is both a cause for concern and a cause to continue the efforts that we have in place and to follow the directives that Secretary Smith is putting out to try to maintain our control of this virus. If you go to the next slide, these are the positive cases. So this is among all tests in Arkansas, what percent are positive each day. Now, early on, we were up above 20%, and that's a little bit misleading because we were only testing people who actively had symptoms that were over age 65 and those with comorbidities because we had so few tests. As we now go out into the state and tests are now readily available, and in fact, if anyone has symptoms or suspects that they have been exposed to an individual with COVID-19, the strong recommendation now is to seek a test to find out if you have become infected and should kind of self-isolate. We're hovering now around 5% of the tests done each day as a positive test. This is one of the markers that I'm following, the number of positive tests, the number of tests or the hotspots in counties, and the number of hospitalizations. Those are still probably the 3 most important sentinel indicators that we're watching. And those tests, if we stay around 5%, I think that represents the number of people that are out in the community that are infected. If we look at our state compared to other states, we have, you know, had a relatively low dose, if you will. Unfortunately, Louisiana got hit around Mardi Gras with the virus coming into New Orleans, and they took a big hit. Shreveport is now, as I mentioned before, a hotspot. Mississippi also has a higher burden of cases per 100,000 people. We in Oklahoma have escaped so far. The next slide will show how many tests we're doing per person. This is a concern. We're still, even though the governor is pleased with 2,000 tests a day, that still gets us only to about 2% of the state population by the end of the month that will have had a test. So we really don't have good line of sight yet on where the infection is spreading quickly or in which communities it is moving most rapidly. And finally, this is a good number, the number of hospitalizations when people do get COVID-19 and they do get sick and they do have more severe symptoms of hypoxia or more of the pneumonias, they do get hospitalized. And this is a strong indicator that I think we have maintained support and control of this infection. Now in the news, you're hearing a lot of things, and it's relatively confusing because it's complex, and it's more confusing because you have different CEOs wanting their stock price to go up, so they're talking about their drug or their vaccine. So I want to take just a minute and do a little bit of immunology 101. As I mentioned, this is a new virus. Our bodies have never seen it, so our immune system doesn't recognize it. So this is a little animated effect that if Sandra will start, I'll walk us through. You're walking along and this new virus is out in the environment. It's not going to let us play it, is it, Sandra? Let's go back to immunology 101 and I'll walk people through it. Basically you're walking along, you get infected. The way this infection is passed is principally through respiratory droplets. It's a respiratory infection. Somebody coughs, somebody sneezes, somebody's close and you are exposed to their respiratory droplets. The droplets are usually, this is the 6-foot space. They don't move very far beyond 6 feet. They are affected by gravity, and so they can come down on hard surfaces, which is why the recommendation is to wipe your workplace, wipe your hard surfaces, and importantly, wash your hands frequently and periodically. Your body gets infected, you may not even know it. So for the first 4 or 5 days, you may be infected and infectious and spreading the virus, and you don't even feel bad because your immune system hasn't recognized it as a threat. For many of us, we may never feel bad, or it may be so mild that we don't recognize that we've had it at all. And that's the reason that we're asking people to wear facial coverings, so that if they are infected and infectious and don't feel bad, they're not spreading the virus more. As if you are going to have symptoms, your body revs up, you start to feel bad, you get a fever. The 4 most common symptoms here are a dry cough, fever, shortness of breath, and interestingly with this virus, about 85% of the time, people lose their sense of taste or smell. So if you lose your sense of taste or smell, by definition, you are almost guaranteed to be infected with COVID-19, and you should seek a test and you should self-isolate and quarantine. Your body revs its immune system up. You start making antibodies. You'll hear people as they recover and they are without symptoms, they can donate their plasma so that other people that are having a tougher time can have a plasma transfer to get some of the juicy reactionary interferon and other responses that your immune system has developed. You'll start making an antibody called IgM. That is a short-term antibody, and then it goes away. Later on, you'll make an antibody called IgG, and that is what is potentially going to give you longer-term immunity. You hear people talking about the IgM and the IgG tests now. We don't know if that IgG antibody lasts a long time, maybe forever, like measles, so that you don't need to get another, you can't get it if you've had it one time, or whether it wanes and that, this may be a seasonal infection like the flu virus that comes back each year. So those are some things around, the development, the exposure, the antibodies, and we can come back as we talk about testing and put a little more context to that. So let's go forward. There are 2 types of testing. One is a molecular test, actually looking for the DNA or the RNA of the virus itself. And this is what tells if you're actively infected. The other are those antibody tests where they have to draw your blood and actually test for the antibody after you have become infected. To date, most of our tests and still are recommended to be those diagnostic tests to say, are you actively infected today? Originally, the FDA had put out they had let some antibody tests come out that had low standards. They weren't very good tests. As much as 30% of the time, the results you got would be wrong. It would say, yes, you've had it when you actually hadn't, or no, you hadn't when you actually had. False negative, false positive tests. They've since tightened the rules for those manufacturers, and now there's some minimum quality standards. Working with the Children's Hospital team, their lab is still not confident in the antibody tests, so they're solely doing the molecular or the diagnostic tests. And I think 3 or 4 weeks from now, we'll have the bad test identified and kind of flushed out of the system. And by June, some of those antibody tests may be more reliable to find out, have you been exposed? Did you have an asymptomatic infection and not know it? And whether you have that IgG antibody that could potentially provide some longer lasting immunity. So this is the situation on testing. Now, some of the guidance on what you should do if you think you have been exposed or you actually come down with symptoms. If you think that if you either know you've been exposed to someone with COVID-19 or you suspect you've been exposed, the recommendation is that you quarantine yourself at home for 14 days. The reason for 14 days is the incubation period for COVID-19 can be up to 14 days. Most people get symptoms if they're going to be ill within the first 5 to 10 days, but many people never get symptoms at all. They may be infected and they may be infectious. So the recommendation is to quarantine if you know or suspect you've been exposed for 14 days. Now, if you come down with an illness that is like COVID-19, again, headache, fever, cough, loss of smell, you should call ahead to your doctor's office or one of the drive-through testing sites and go get tested now. If you have these symptoms, how do you know? You should also self-isolate and not be going to Lowe's or Walmart or the grocery store. Have other people bringing you food and try to stay in. Most of the time, this is a self-limited condition that you can treat with, Tylenol, antibiotics, fluids. It's kind of like the flu. How do you know when you can come out? There are 2 conditions that you know that you can come out of your self-imposed isolation. One is, the 2 are, it needs to be at least 3 days since your resolution of symptoms, since you've recovered. So no fever with not taking any antipyretics, and improvement, if not resolution, of your respiratory symptoms. And originally it was 7. The CDC has changed this to be 10 days since your symptoms first appeared. So if you are sick or if you know you have COVID-19, it's 3 days since resolution of your symptoms and 10 days since onset of your symptoms. That's when you know that it's safe for you to come back and to rejoin your family, go back to work, things like that. Now, what about the mask recommendations? I think this is one of those things that is difficult to communicate, but it's important. You're wearing a facial covering, and it does not need to be a medical mask, but you're wearing a facial covering not to keep yourself from getting infected. Again, the way you get infected are respiratory droplets that either you breathe in, you have on your hands and you touch your mouth, or it can come through your eyes. It's to keep asymptomatic people, you have it, from infecting other people before you come down with symptoms. So, when social distancing doesn't work, you can't guarantee to be 6 feet apart, you should wear a mask to prevent yourself from infecting others. I tell people on our municipal league and chamber calls, if you walk into a public place of establishment and more than 90% of people aren't wearing a mask, you need to turn around and walk out because you're putting yourself at risk. And obviously the individual hygiene of hand washing, environmental safeguarding, increasing the periodicity that you're wiping, common areas down, and social distancing continue to be the best protective measure. The mask is just our own individual responsibility to help protect those that we're around, and when you go out in public, to keep yourself from infecting others. Now we're starting to have new therapeutic strategies come online that you're hearing about in the news. The first group are drugs, and they're really kind of 3 different groups. The first are antiviral drugs. Remdesivir is one that you heard about 10 days to 2 weeks ago, actually a clinical trial that showed in very sick individuals, remdesivir shortened the hospital stay by about four days and they lowered the mortality rate by 30%. So this was a good positive first contribution of, you know, an antiviral. You see the names of others. I won't pronounce them. I don't know why the pharmaceutical company comes up with names that are basically hieroglyphics in a way. The second big group are immunomodulating drugs. These are drugs that try to rev your immune system up. And finally, I call them some wild card drugs, drugs that some are advocating may have an effect, but for which there is no good evidence. Hydroxychloroquine and chloroquine are one that obviously is in the news. Azithromycin, and some people advocate taking those two together. Again, any drug has adverse side effects, and so you want to make sure that what you're taking is going to be good for you. And I think you're going to hear in the next few weeks, particularly the antivirals and the immunomodulating drugs, some good studies that have tested and can help us guide those. The second major therapeutic strategy are passive immunity. We talked about the plasma donations and potential transfers. Those are passively giving a person who's recovered their serum to somebody who's sick and may not be doing as well. Over time, as we develop those IgG antibodies, we may be able to donate those and have a concentration of the antibody or the immunoglobulin given to other individuals. We do that now for healthcare workers that get a needle stick with an individual's blood that is HIV infected or others. And then you'll start to hear some of the pharmaceutical companies talk about making monoclonal antibodies, actually chemically making an antibody that attaches to the virus that then acts as a flag for your immune system to say, here is this new threat. Here's a flag on a virus that your immune system needs to respond to. And finally, obviously, what we all hope for is a vaccine at some point in time, like the flu vaccine or the measles vaccine, that we can take and have protection from this virus without actually having to be actively infected by the virus itself. The vaccine effectively tricks your immune system into understanding that, yes, this is a threat. Now, I think one of the things that is a hope, but not necessarily a promise, is vaccines take a long time to create. Usually, it takes several years to develop a vaccine, and that's because before you're going to inject a healthy person with something that could cause them harm, you've got to go through a series of phases in testing. Phase 1 is usually a safety trial to make sure the vaccine doesn't cause harm. And we've had vaccines then historically that have in their development been halted because they did cause people harm. Then in phase 2, you want to make sure that it is effective against the virus, that if you're going to give somebody a vaccine, it actually works. And then phase 3 is you want it to last. You don't want to give somebody a vaccine that works, but it only works for 2 weeks. You want it to last for a long period of time. So usually this can take several years. Currently, the FDA has accelerated the time development, and we now have over 100 vaccines being developed. I think there are about half a dozen that are actually in some sort of first phase clinical trial. So I think we're hopeful for a vaccine. I think the earliest that's likely to be available would be sometime in early 2021. So we've shut down, we have mitigated, we have kept the purple spike from overwhelming our healthcare system, but we're now having to come back out. The guidelines that Dr. Birx and Fauci put out from the White House, I think were wise and made sense. Reopening based on a gating strategy. Let's loosen a little bit, wait 3 weeks and see what happens. Obviously, it's at the state's discretion, and you see in the news each state taking somewhat different approaches, but most are trying to adhere to, having individuals with symptoms stay at a level, new cases stay at an acceptable level, and obviously the healthcare system not be overwhelmed. Governor Hutchinson put out or formed 3 different committees. If we can go to the next slide. The Medical Advisory Committee, you've got an Economic Recovery Task Force and a testing group coming out. Those have put in place some of the phased approaches to reopening. You see on the next slide the list of dates that we have passed of things that now are able to reopen. This is not a requirement to reopen. This is a loosening of the public health emergency to close. So these entities can be open. On the next slide, you see where we are now and where we're going. The summer camps and team sports are really the ones yet to, and the freestanding bars are yet to have their guidance put out. Our center looked through all of these directives. So these were directives that were targeted at specific types of organizations. And we said, well, what are the common themes for other places of public exposure? So signage is important to make sure that everybody both is aware and maintains a high vigilance for recognizing the virus is still out there. It is even more prevalent. It is just as infectious. Our bodies are no more immune to it. This is not like a tornado warning that's passed and now the threat is gone. This threat is still present and actually probably even more prevalent in our communities. Disinfecting, I mean, this virus does get killed with common disinfecting strategies. So increasing the wiping of common surfaces that people touch. Screenings, these include temperature checks and 3 questions that I think are important. I modify the 3rd question a little bit. 3 questions are, have you traveled to an area which has an acute outbreak of COVID-19 like Memphis or like Shreveport in our region? Or have you been around someone that you know had COVID or suspect had COVID-19? And the 3rd is, do you have symptoms? And what I modify is I say you or anybody else in your family, because if somebody else in your family has symptoms, you have probably been exposed also. Mandatory facial coverings, physical distancing. This is really logic, not science. If you're in an office-based situation and you know it's respiratorily spread, if you can face away from each other, the chances of you contaminating each other goes down. If you're facing towards each other, the chance goes up. So some of this is looking at your own local environment and saying, what can I do to help decrease my chances of being exposed? The occupancy limits, I think there's a pretty clear phase 1 in Arkansas is a 30% capacity. Phase 2, I think, will be a 60%. Then we'll go to phase 3, which will be full capacity. Limiting self-service, common areas, not having a kitchen that everybody's coming to for, common efforts for a while. Protective equipment where appropriate. And then obviously if it's a nursing home or some other closed facility requiring the residency requirements there. Now we've got a few examples that are interesting that give us a little bit of idea about this virus. One is the Cummins Experience that has both, I think, good news and bad news. First, the bad news. This virus appears to be incredibly infectious. Now, a prison situation is a closed situation. That's not our community, but they had a first inmate that tested positive for COVID-19. They went in and tested the rest of his barrack mates and found 43 of the 46 infected at that point in time. They then tested all 1,100 inmates and they found that over 800 were actively infected, 900 positive cases out of 1,100. So I think this shows how infectious the virus is. That's the bad news. I think the good news is, the individuals that had severe illnesses was about 1%, and the death rate was a little less than that. So, it's lower than the 2 to 3% death rate that was originally feared. It is a serious illness for some individuals, particularly those individuals, it appears, that have chronic lung conditions, COPD, coronary artery disease, or have diabetes. And I think those are because the bodies of those individuals have more physiologic age. They're less able to mount a response to the virus itself. A couple of other examples that we know from other places. Santa Clara County in California had one of the better antibody tests, and they actually randomly tested 3,300 people to see how many had past infection. About 2 to 4% of their whole county had previous infection. This would represent somewhere between 50 and 80,000 of their 1.9 million population. So I think this virus is going to be in our communities. Many of us are going to get it. We're going to need to try to slow its spread and protect individuals who may have susceptibility, either because of comorbid conditions or individuals that are on chemotherapy or any other type of immunosuppressant that couldn't mount a response when their body comes in contact. Now, last weekend in the Democrat Gazette, they reprinted a story from the New York Times as, well, why is this not seeming to be the same experience across the world? I think the first is younger populations are largely spared here. Italy, Spain, Belgium have older populations, and therefore their death rates were much higher as the virus transmitted through their populations. Another one is cultural factors. we're lucky in that here in Arkansas, we didn't have nonstop flights from Asia. We are relatively social distanced by being a relatively rural population and a decentralized city. We don't have the densely urban populations. There is some suggestion that warmer weather, higher humidity, I think for sure sunlight and ultraviolet light does kill this virus. Although it's counterbalanced because none of us have seen this virus before in some of the warmest places. Iraq and Australia are having high levels of outbreak. So I do not think summer is going to make this miraculously go away because none of us have seen it. Those locations and those states that successfully achieved lockdowns earlier have had success. And then finally, candidly, it's luck. It's where the virus got sprinkled and who got exposed. I do want to emphasize what happened up to this point is largely based upon luck and the emergency actions that we took. What happens going forward is not going to be based on luck. It's going to be based on how we now recognize this virus is in our environment. It is as infectious as it ever was. It's probably more prevalent. And it's how we put some of the safeguards in place, both to keep the transmission rate acceptable and to protect those who may have risk factors that would cause them to have more negative outcomes. Now you hear about this model. It's the Institute for Healthcare Measurement and Evaluation model out of Seattle. They initially launched their model in March. They've been updating it. It combines some of the issues about hospital resource demand. They've now added social distancing, and it enables us to predict a resurgence if we don't see the continued control that we've been able to achieve. They've got a couple of models out, first for the United States, that suggest that we could see as many as 145,000 deaths by August 4th. And this is, again, with continued control that we have achieved now. In the state of Arkansas, their projection is for about 115 deaths. We're at 100 now, so hopefully this death rate will become true so that we don't lose many more people. But all of this is because we're going to control and maintain control of the transmission rate. We try to put out the information as we can. Sandra's great on putting a newsletter out each week on Thursday. We would encourage you to sign up for it, distribute it to your friends, to others who may be of interest. And Nate, I'll be glad to take any questions you have from your readership. And I know you had a couple that you posed earlier. Let me turn it over to you and we'll go from there.
Thanks, Joe. We did have a couple of questions that came before we started. We appreciate your covering the waterfront for us, giving us all that background. There are several questions that specifically relate to us. Here's one. If we find ourselves with limited cleaning and sanitation supplies, how should we prioritize the use? What are the things that you ought to use your limited resources on to clean?
Well, first, and I want to emphasize this, a diluted solution of bleach is an effective cleaning material. So I think for the most part, we're beyond the runs on stores where bleach is not available. So I think just a diluted thing of bleach is an easily acceptable and readily available and effective source. So, I think you would prioritize, and I would recommend prioritizing where you've got the most exposure to recurrent people. Now, in your situation in the library, whether I'm downtown or I'm in the Hillary Clinton Library or others, you've got ingress and egress pathways, you've got doors with handles, you've got your desks where people are going to be coming to. I think those are going to be the places that you're going to have some systematic way that every 30 minutes or so you're wiping those down so that you're trying to actually minimize the potential that an infected individual comes and that the virus could rest there for a long period of time.
All right. If we've seen some other libraries that are essentially drafting plans to let vulnerable populations in, only vulnerable populations in at specific times. There's a danger in that. I went to Trader Joe's the other day and they told me I was old enough to come to the early hours. I was insulted by that. But if we want to do something like that, what are the additional precautions we could add onto that besides having vulnerable populations come, say, from 9 to 10 or 10 to 11?
I think this was one of the innovative things we saw in our grocery stores and chains, that recognizing that particularly elderly may have more susceptibility or may have worse outcomes if they become infected. They did have early hours, and the concept there is most of the time the floors were cleaned at night, the environment was decontaminated with overnight cleaning, and so therefore the safest time for an individual with risks was to come at the first part of the day. And I think you and your libraries could consider something like that, and probably would be much appreciated by the older members of our community.
Here's another one. If we have individual study rooms, that's going to be a challenge, but if we allow patrons to come in and use them and we're unable to adequately clean every one of them, is there a period of time that you feel safe? Say, let's not let anybody in there for the next X period of time in case we can't get in and clean it behind every use, and we'd be reasonably safe that any droplets that had landed on a surface would be dormant or inactive.
So I think this is where, our understanding of this virus is still evolving. I think for the most part, people will say the virus can't survive more than 12 hours, without and remain infectious. Now, one thing, and again, this is where logic is going to rule. I think you could actually encourage your patrons with just having a disinfectant wipe to, when they go in, wipe it down, and when they leave, wipe it down. And therefore, it's not dependent upon professional cleaning staff, but there's also, some personal responsibility to clean that area or have that as a requirement for use of the area, both to help an individual feel confident that it is clean when they go in, but they're also leaving it clean. And I'm talking about the tabletop and the chair. There's no reason to get down and mop the floor, but right. The contact area where an individual would be is probably important to be wiped down in between uses. I would also encourage, inside of a closed space, we're starting to see, and you see these in the recommendations for restaurants and others, family units that are together at home can probably be inside of one of your individual units and not be wearing masks. But if they're out in the common areas, then you're going to want to have a facial covering requirement of almost everyone, if not everyone that's entering the library.
We have offered through the governor's office to have some of our staff detailed for contact tracing that the health department is starting to do. I'd seen in the newspaper that some library, maybe it's California or someplace. I've also seen one more recently in Forsyth, Georgia is doing this. Is there something we as novices to contact tracing might need to know about? They're going to train our staff
Sure.
who are tasked with this, but what are the challenges in contact tracing that we might be alerted to before we do that?
Sure, and just to go back, a public health response when you have a new infectious disease is try to isolate and quarantine that infected individual or individuals so it doesn't escape out into the community. We tried that early with this virus and we lost control, and that's why we had to go into the mitigation strategy of shutting everything down. As we come back, the health department strategy is going to go back to trying to identify individuals that are infected, have them self-quarantine, and then track down others who may have come in contact. And for the most part, the CDC is defining contact as 30 minutes within 6 feet, being within 6 feet of an individual for 30 minutes or more. So most of your contacts there with transient individuals coming through the library is not going to qualify necessarily as a contact. But that's the contact tracing that the health department's putting in place now. You're obviously going to have individuals come in that are unknowingly infected, and that at some point in time, the health department's going to get a positive test. They're going to trace them back. They're going to say, well, I went to the library, then, knowing what time they came to the library or whatever, who else was there. That it's about who was present and how intimate was the exposure. Right now, they're considering a contact, again, within 6 feet of somebody for at least 30 minutes. So most of your transition folks are not going to have qualifications for a true contact in the health department sense.
One final thing I've seen around, and we've put up these acrylic sneeze shields at our service areas. Is that a helpful thing generally?
I think it is a logical approach. Again, this is logic over science. There's no study out there that says the plastic shield does anything, but logic does. If this is spread by respiratory droplets, and it's obvious when somebody coughs or sneezes that is a potential exposure, but it's also just in conversations. I mean, you can't help but having some transmission or expulsion, if you will, of respiratory droplets. So that plastic shield does put a barrier, which is an effective barrier between two individuals that's having a conversation. And I think that's a wise, logical, and probably comforting strategy to put in place.
Sandra, I don't see any other questions in the chat. If anybody else has got a question.
There's one on what's the best resource to track areas that are considered a hotspot. Yeah, I think there are two parts to this, and one is obviously the health department, the CDC and others are tracking positive cases in the state, and you can somewhat take advantage of that. We're going a little farther. I mean, they don't want to call a hotspot, because of the stigmatizing aspect, and you're going to make any mayor upset when you call them a hotspot. We're going a little farther, and I would encourage you to our e-newsletter is going to be a good place. We're going to call it like we see it, and so I'm calling Memphis and I'm calling Shreveport a hotspot right now, although I don't know that you're going to hear the governor or Secretary Smith actually be that explicit. So I think pay attention to those positive case reports each day. But I think we're glad to be able to be a little more explicit on saying where I would recommend you not plan your weekend vacation for Memorial Day.
There's one other question, Dr. Thompson. Somebody saying if we see somebody in the building and they obviously are manifesting symptoms, what's the way to do it? Some of our librarians have noted they're not very good bouncers, so we may need a little training in this.
I think there is a simple, non-threatening, way to approach this. If you've got a patron that clearly is coughing, it is mainly a cough, a random sneeze. We're in allergy season. The sneeze is not a typical symptom for COVID-19, but a dry cough is. I think you can easily say, I'm concerned about your health. Have you gotten a COVID-19 test? They're readily available now. I think there are a lot of people who still think, well, let me not go get a test. And now the strong recommendation is we have enough tests. Let's go get it. If you are positive, then let's take appropriate precautions and get you to isolate so that you don't contribute to the rapid spread around the group.
Let's try to get in one more question, then we'll let you go. If we're all wearing masks inside the library, and let's say we handle the same piece of paper or some common object, what's the risk in that if we're all wearing masks and I guess in theory not spreading our droplets?
So I had a little heads up on the municipal call that you may have been on from one of the local communities asking about the library reopening. And so we did a little bit of background work. There's not much science on this, but I think there was a good CDC Institute of Medicine document that we can get for you that looked at, logical recommendations of how to deal with books that have been out. And clearly you loan a textbook, somebody's going to sneeze on it and they're going to turn it back in. How long does the virus stay potentially infectious? The recommendation there, and somewhat tongue-in-cheek, think you may want to consider, is putting returned books into quarantine for 24 hours. The virus is not going to live long on paper, but it is possible that it's there. So a return book, if you could let it lay for 24 hours, I think you're fine. If it's something that has a more of a slick surface, like a DVD or a CD that has a plastic cover, wiping that down with a disinfectant as they come back in should be fine. But I don't think this is going to be an occupational threat if we just use a little bit of logic as things get brought back in, and you're continuing to do the good work that the library has in its place.
Sandra, thanks again for putting this together, and Dr. Thompson, we appreciate your sharing an hour with us, and we may have other things. We're going to try to link this to our website so the rest of the staff can see it, the people who weren't on this and people who were in the community generally. So we will spread this information and try not to spread the virus.
Nate, this is a new virus. I just want to repeat, it's just as infectious as it was 3 months ago. It's just as harmful, particularly for individuals with risk factors. We all need to do our part to mitigate the likelihood of it transmitting. Many of us are going to get it, and we're going to be fine as we do. And our healthcare system is going to be there for those of us that need support. But I really do want to emphasize this thing is going to evolve. We're in uncharted waters that we've never been in before. As it does so, Sandra and I'll be glad to come back. If those of you that are watching or those that will watch, if y'all have questions, feel free to come on our website, post them. We'll try to get back to you, or at least get them to you as quickly as we can find answers.
I bet we'll do that. Thanks
Great.
again. Appreciate
Thanks
you.
for having us.
Stay healthy.